Welcome and thank you for joining us for today's Lunch and Learn session, Meet Your Domestic Family Violence Local Link. My name is Sydney Cruikshank and I'm from the PHN Education team. I'm joined today by Dr. Alison Lancey, who is a GP and the RECGP Deputy Head of Training for the Hunter, Manning and Central Coast. Tammy Nicholson and Tracy Rogers from the Newcastle Domestic and Family Violence Local Link, and Steph Sass, who is a Flexible Project Officer with the PHN. Before we begin, I'd like to pay respects to elders past, present, and emerging, and I'd like to acknowledge the traditional custodians of the land that we live and work on. For me, that is Dark Injured Land. A few housekeeping things before we get going. This session will be recorded and available for you to view in our education library, along with a copy of the slides in a few days' time. As attendees, your camera and microphone are automatically disabled. However, if you have any questions during the presentation, please just pop them in the question box, which you will find located in your control panel. An evaluation will also come to you after this session. Your feedback is extremely important as it enables us to provide future education. Now, it is my great pleasure to introduce Dr. Alison Lancey.
Hi, thanks Sydney for that. And I'd like to acknowledge the traditional owners of the land that I'm on today, which is a Wabakal land. So I'm here in the PHN office. So thank you very much to everyone who's joining us today to talk about the new program that the PHN is running. And I'm really excited about it. And so I've been working with these guys for the last couple of months. And if you're interested, I can definitely come in and do some more teaching and education on this for your practice, and I'll talk about that as we go. Just to give you a little bit of background as well, so the Safe and Healthy Primary Care Domestic Family Violence and Abuse Initiative, it's a Commonwealth funded pilot, so it's providing free training to primary care providers in this area. And so we've been doing teaching in Newcastle, I've done practice at Raymond Terrace. This goes up to Taree, down Tamworth, Central Coast. So it's quite a large area, and up the valley as well. So it's quite a large area that's being covered. And we're trying to increase the confidence of people working in primary care to spot the signs of domestic and family violence and abuse, to start conversations with their patients, and then to be able to link for ongoing support. So as part of this, the pilot has funding new positions, and that will be your domestic family violence local link, who you will also get to meet today if you haven't already, who's Tammy Nicholson. And we're also I'm very pleased that we've got Tracy Rogers here as well, who works as an Aboriginal caseworker. So you'll get to meet those as well later on in the presentation. So the reason why I'm so excited about this, I guess, in the past working as a GP, it's really stressful when you had, a woman that would come and you might ask the question if they were experiencing family and domestic violence and abuse. And if they said yes, then it was always such a heart sink moment. Like, now what do I do? And then, you kind of were like, well, here's some numbers, good luck with that. And then you try and see them again. And I always felt really helpless as a GP. And I wasn't quite sure if I was doing the right thing, if I was providing enough support, all those sorts of stuff. So I was really, really excited last year when I was doing education with our GP registrars on this topic to find out that this pilot is occurring here. And I was able to get the PHN guys to come in and talk to our registrars. And so that's kind of how I've started to work with them. And it's so fantastic now to be able to have this local link person. And so for you guys today, it's Tammy Nicholson. And it's just so fantastic to know that you've got someone that you can call, that if you do a referral, someone that you're concerned about, that someone's going to see it, someone will follow them up. Because what we do know from the evidence is that the highest burden disease for women aged 18 to 44 years is domestic family violence and abuse. So it accounts for about 5% of chronic disease, and that's in the impact of illness that occurs in relation to that, disability, premature death. It's much higher than, alcohol, obesity, inactivity, tobacco, for women in that age group. So it's actually a public health issue now, and it costs the health system a massive amount of money. So we're nearly looking at $1.5 billion just to the health system. And in terms of the cost to us as a society as a whole, it's $22 billion. And that's, lost days of work, the economic disadvantage that occurs, the cost of the health system. It's a massive amount of money. And that's just the economic costs. That's not the the emotional and the disease cost and all of the things that happen for people personally as well. And then what we also know is that that disease burden will be higher for anyone of Aboriginal Torres Strait Islander background. And we certainly see the higher rates in those groups. And we also see people in other minorities that are quite significantly affected. So if you have a disability, non-English speaking background, refugee, so all of those groups are much higher risk of that ongoing chronic disease and that disease burden. And so these are the statistics that we're trying to address with this program. And what we also know from the evidence is that the person that someone is most likely to disclose to that they are experiencing domestic family violence or abuse will be a friend or family member. And then after that, it's their GP. And so that's why we're coming out to the practices and we're trying to do this education, and we're trying to bring domestic family violence to the forefront of everyone's mind, so that you're thinking about asking that question, and it becomes normal to ask that question of your patients just generally across the board in lots of different encounters. So what we do know is that women appreciate being asked, even if it's not happening to them. It immediately identifies you, the GP, or a family member or friend as someone that cares, that has asked that question. So if they do experience that, or maybe they didn't want to disclose there and then on that day, you're identified as a person that they will come back to and likely disclose to you later if it is occurring. So the general practitioners are extremely important in this process. The other thing that we do know is that if you're a full-time GP, if you're seeing a regular patient load, about 5 of your patients each week will be current or previous victim of domestic family violence. And so one of the stories that I tell frequently is when we were doing this presentation a couple of years ago, we had a male registrar when we're presenting to our GP registrars who put in their feedback to us. I don't know why I needed to sit through this session. I'm a male GP, I'm not going to be seeing a lot of these women. It's kind of a bit of a waste of time for me to sit through this. And so what we also know from the statistics is that it doesn't matter about your gender as as a practitioner, that women are just as likely to disclose to male GPs as they are female GPs. The important thing is that they're asked. And if you ask women, then they identify you as someone that is a safe person to disclose to later on. So we're trying to make this this public health issue that is a huge cost to our society and a huge burden of disease for women in that sort of 18 to 44 year age group. We're trying to make it more visible in primary care. We're trying to make asking it more common and bring it to the forefront of our brain. So in terms of the primary care response, they're kind of trying to make it as simple as possible, and it's about spotting the signs of domestic family violence, and there's some of the things that I will come out and do as education in your practice. So I've been doing quite a few lately, and they're great fun, particularly the first session, because that's a whole of practice. And so the ones I've been doing lately, I've had far more reception staff, admin staff attend those than GPs, and those conversations have been fantastic. I've really presented as a primary public health issue about, what if this is happening to your friends or family? This is how you can spot the signs. This is how you can start the conversation. This is what you can do. And so we've been having these amazing conversations with the practice staff and thinking about how the whole of practice can support these women as well. And so it's just been so fantastic and enjoyable. So if you haven't had myself or one of the other trainers come into your practice, please contact Steph and she will set that up, because I'm having a great time coming and I'm meeting all of the practices lately and doing this training. And So in terms of spotting signs, I'm not going to go into that today, but certainly it's asking the question. So early intervention starts with that conversation. It starts with us, asking the question, and it's going to be, general, and I quite like that sort of normalizing statements to begin with. Working out situations where you would just normally ask it in your regular consult. So whether that might be doing cervical screening, women's well check, over 45 health checks, your 715s, all of those kind of your chronic disease management plans, any kind of situation where you can say, well, I ask all of my patients these questions. So, how are things at home? How is your relationship with your partner? Those very nice normalizing statements. We do not believe that domestic violence is common. So is it all right if I ask if this has ever happened to you before? Very broad statements that can be asked really in any kind of consult, to be honest. I have this conversation with our registrars. It's nice to kind of preempt that you're going to ask that before you launch into it, because some patients get a bit thrown, but it's certainly important to ask. And then you can drill down to those more direct questions. Often these patients are the ones presenting with somatic symptoms, mental health staff. You can't quite get a handle on what's happening. They might be, not particularly frequent at the practice, and they really sometimes can be really tricky to get to the bottom, and they might not be ready to disclose. But that's when you can say, and I really like this question, is there anything else that's happening that might be affecting your health? Or is anything happening at home that's causing you additional worry? And those sorts of questions can start to draw things out. And it might just be, oh yeah, my partner and I have been fighting a lot recently. And then great, you've got an in. Oh, what happens when you're having those fights? Does your partner ever get angry? Has they ever hurt you? Have you ever been in a situation where you've had force used against you? That's where you can start taking the conversation, and trying to pick up on that, I think, is really important. So asking the question is really important, and then listening without judgment. And one of the things that I sit in and do a lot of teaching visits with registrars, and one of the things that I talk to them about is that kind of active listening, because I have had registrars where patient is telling them this stuff, it might be good things, oh, I've just recently started exercising and I've lost weight recently and I've really cut down my alcohol. And I have seen this with the registrars go, okay, good. So are your immunisations up to date? And I really have to go, oh, it's really, really important to acknowledge that you've heard somebody. And I think that's part of that active listening. So it's really important to say those words, oh, I hear what you're saying, I believe what you're saying, because that's why people that often don't want to disclose what's happening, because they're worried about not being believed. This is really important. I'm here to help you work through this. I'm really keen to continue to see you. I believe what you're saying. It's really, really important to say. And then validating the feelings and validating the response that they're having. I'm so sorry that this is happening to you. Everyone deserves to feel safe at home. Thank you for telling me this is not your fault. Because we do know that there's a lot of guilt that goes with people that are experiencing this. And this is why it takes such a long time for people to decide to leave a relationship if they're wanting to leave. It takes 5 to 10 years in a lot of cases, because there's just so much guilt, so many feelings that go with someone experiencing this situation. And then it's about encouraging action. So, do you mind if I ask you some more questions about your risk to help keep you safe? Before we leave, I'd like to help develop a safety plan. And that safety planning, or the risk assessment and that sort of stuff, is stuff that I will talk about with you if I come out and do the education with you in your practice. And getting that consent, is that I would like to link you in with our local support service, with our domestic family violence link. Is that okay? Getting that consent is really important. But we will talk about consent and the need to get that in a really high-risk situation later. So this is the new action plan that the PHN have got. So that is available on the PHN website, and if Tammy's been out to your practice, she might have shown your practice manager how to download this, but it can be downloaded into best practice or medical director, and it will auto-populate part of the patient details on the first page. So I know that's quite small, you won't be able to read that, but basically it's a 3-page referral that you can do. So if you see somebody in your practice and you see a woman and you decide, yep, you know, actually I really want to refer this person to Tammy, this is the referral form to do it on. And so the first page, it will auto-populate with the patient's details, but it's really important that you look at that because there's a couple of additional things, additional contacts, maybe safe hours to contact, and those sorts of things that you'll need to fill out yourself. Tammy's happy to accept a referral with just that first page if that's all you have time to do. Obviously, it's really helpful to do the risk assessment, which is the second page. And that's basically 10 questions looking at the most high risk kind of situations. And the top 3 questions are, do you feel safe to go home now after this visit? And if the answer to that is no, well, then that's kind of like you can call Tammy straight away to try and link someone in. But things like, you know, is this behaviour or is this getting worse is another kind of high risk question. And then issues or questions around, have they ever had pressure applied to their neck? Is there strangulation that's occurred? Because again, are very high risk situations. So even if you're able to do a couple of those, ask a couple of those risk questions, that's very helpful for Tammy. And then the third page is about safety planning. And if I come out to your practice, I'll talk through that with you. Tammy can talk through that with you as well if she comes out to the practice. And this is the referral form. It can be sent through medical objects or can be faxed if that's the way that you're sending referrals as well. So now I'll hand over to Tammy and to Tracy as well if they would like to talk about their roles here in the local area.
Thank you, Alison. I'd also like to acknowledge the Awabakal people whose land I meet with you all on today. And I'd also like to thank those of you who have taken time out of your busy schedules to attend. So I am the local link for Newcastle and Lake Macquarie areas. When I attend practices, I will actually discuss ways in which the Newcastle Women's Domestic Violence Court Service can assist you with your patients who are actually experiencing domestic and family violence. I thought it would be interesting to give you a few statistics as well while I'm at it. So approximately 90% of our referrals that we receive at the moment come through from police. When they attend a DV incident, we automatically get a referral for that family. The other is government departments, as well as all of your support services as well. So a little bit of insight into the amount of clients that we do actually see here in service in the past calendar year. So in 2022, we received approximately 6,000 referrals. And out of those 6,000 referrals, we probably had contact with about 4,500 of those. So far to date, so January and February this year, we've already had 950 referrals. I thought I might break it down just so you could understand the importance of having our focus workers as well. So we do have statistics in relation to the identified groups. So 16% of those referrals are from disability and 20% are from our Aboriginal and Torres Strait Islanders, 3% from our LGBTIQA+ group, and 8% from women over the age of 55. Now, in that past 2 months, so from January 2023, 12 of those women in that over 55 groups were actually over 85. So it's quite significant. So when we receive a referral here at the WDV CAS, so once you fill out that GP action plan and you send that through, we'll contact that patient within the first 24 hours. If we don't get them after the first 24 hours, we'll try them again in the second 24. And if we don't get them again, we'll try them in the third 24 hours. Once we have contact with them, we will triage that client using our own domestic violence assessment tool, which is a series of 24 questions. Now, at that time, we will then deem them to be either at threat or serious threat. And if it is at serious threat, that means that something needs to be done immediately to support that person. And we'll refer that through to something which is called a safety action meeting. So in each local coordination point, so Newcastle and Lake Macquarie, there is a safety action meeting. Now that safety action meeting is attended by key representatives from the community. The chair is the Detective Chief Inspector of any local area. So Lake Macquarie is the Detective Chief Inspector for there, Newcastle Detective Chief Inspector for there. We also have our Domestic Violence Liaison Officers. We also have DCJ Housing, DCJ Child Protection, HNAAH, as well as Community Corrections and Department of Education, and then all of your local supports as well. So every person who attends that meeting at the Safety Action meeting, which is held once a fortnight in that local area, they must be able to make a decision then and there to then mitigate the risk to that patient or victim and their children. Now, it's important to note too that not only, it's not just females that are on a safety action meeting, males are also victims as well, okay? So once we do contact somebody and we have triaged them, we'll then put supports in place for them. And once we do that, we'll then feed back that information to the GP. So it might be that we've attempted them the 3 times and they haven't been able to engage with them. We'll still provide feedback back to the GP to let them know that we haven't had any contact. And it might be something where the practice manager or the nurse puts a little note on that patient's file. So next time they attend and they see the GP, they might be able to highlight that and just say, hey, we did that referral, we didn't actually engage. Is there any other contact methods that they can use to support you? Also, when we talk about supports can be a whole range of things depending on what the client requires. It can be anything from like a victim services application for counselling or financial assistance if they're actually fleeing the property. If they've been a victim of a crime and say it's a sexual assault or something like that, it can also be like a recognition payment. If it's required for a recognition payment for sexual assaults or damage to property and stuff like that, then it would possibly be an on referral through to the Victim Services Vocal, or we also have a Hunter Community Legal Centre as well. WDV-CAS, which is the Women's Domestic Violence Court Service, which is where we're from. We support all victims in local courts. So we attend the Toronto Local Court, Belmont Local Court and Newcastle Local Court. We have support people who actually attend those courts. We have a safe room at those courts. And we also have domestic violence duty scheme solicitors. So if somebody does require further family law advice or anything like that, then they can receive that on the day. Okay, we also do brokerage. We have a small amount of brokerage available, especially for our more complex clients and our case management clients. It might be like brokerage for security cameras. So say somebody is a victim of domestic and family violence, however, they don't have enough evidence as yet to support an application for an ADO. Then we have Wi-Fi cameras available so they can set those cameras up, and if the POI is, you know, threatening or stalking or harassing them, then hopefully that will gather that evidence that they need to get them over the line. We also have obviously safety planning. We safety plan with each victim. We do housing applications, support letters, and we also have the ability to on refer them for legal advice. So in saying that, I mentioned before that we sit in the local courts. We also have the federal court, which is the Children's Court in at Newcastle. We have support workers who work in there. That's the Family Advocacy Support Service. They have a safe room there as well, and they're able to support the women who are going through family law. There is also a male equivalent, which is with Relationships Australia. So if anybody requires a referral through for male support, then we can do that for them as well. Okay. So when we talk about the courts as well, sometimes we all know that women can unfortunately be misidentified as the perpetrator of the violence. It might be that there's been years of violence and You know, she's met her threshold, and for whatever reason, the police have attended, but yet she was the aggressor on this occasion. And she finds that she's then the perpetrator and has an AVO placed against her. Then the domestic violence duty scheme, which is the solicitors that sit in the safe rooms at each of those courts, they can represent them and they can support them, and they can apply for a legal aid application if needed for further support. So we also have focus workers that actually work here. As previously mentioned, we have Aboriginal and Torres Strait Island focus workers, which is Tracy Rogers. Tracy?
Hello. We also have call workers.
And we have LGBTIQA+, disability, aged care focus workers, as well as case managers who have the ability to hold on to people for a more extended period if required. And that you generally find that the people that go into case management are the ones that have come back off of the safety action meeting and they have more complex high needs. At the Newcastle WDV CAS, which is us, we also have a women's safety hub. It's a safe place for face-to-face meeting with those victims who do require a little bit more support. And that's where we use a lot of our brokerage as well. So we might, you know, be able to supply them with food, vouchers and petrol vouchers and stuff like that. The Safe Place Women's Safety Hub is also used for external groups as well that come in, whether it's training for other support services or if it's client group work as well. At the Women's Safety Hub, we also hold things which are called police prosecutor clinics. So if anybody goes to court in the local courts and it gets set for hearing, we have what is called a mock courtroom here at the Women's Safety Hub, and victims can come in here. They can sit through the whole police prosecutor's process, have it explained to them. They can also sit and talk to a police prosecutor who's going to hopefully manage their case on the day. And it's their opportunity to understand more about the court process, alleviate any fears that they might have, and also their opportunity to talk to the police prosecutor if needed. I also have some, when I do attend the practices, it's generally Tracy and I that attend together. We bring out some resources that are pretty useful for the GPs as well and clinicians. A couple of those are, I'll hold them up, but if I come through, you'll see them. But it's just the Women's Safety Hub, and it just explains, this can be given out to patients. So if somebody it's safe to give this to them and they might not want a direct referral immediately, it explains what supports we can do on the back. And if it's safe, you can give them that and they can follow it up after the fact. If it's not safe and you are doing a direct referral to me, then I will get the referral and I will triage them anyway. But if they decide that they're not ready to engage and they're not ready to talk about it, or it might be for fear of retribution or something like that, then we also have these little cards, which are Women's Safety Hub cards. You can give them one of these on the back. So it just looks like they might be attending like a dress shop or something like that. And on the back where it says scan me, if they scan that, it goes directly through to our website and our support service. Okay. There's other stuff that we can drop off as well. The other thing that I thought I might do quickly is maybe just do like a bit of a case study and let you know one case that I've had recently. So I had a GP who gave me a call. They had a patient who came in. It was a male. He had 2 young children and he was married. He went to the GP because he was concerned himself because he felt that his relationship with his wife was impacting the children because they found that they were arguing more frequently, which was escalating, and he had concerns. So the GP gave me a call and he said, look, I don't feel that it's an appropriate referral to do a mental health plan. Is there anything else that you could suggest that may support this male and his family? The good thing at that time is that the Family Referral Service in Newcastle have a new project that they were running, and it's to support male perpetrators of violence and families. So it's all about supporting and changing the behaviour, and that was a more kind of better fit than doing the mental health plan. So I'm not sure if Alison, are you still there? Oh, I should say quickly too how to refer. So if you look up at the moment on the screen, it says your Newcastle DV local link, Tammy Nicholson, which is me. It's got the medical objects ID there, and it's also got the fax, phone and mobile number. If you have any questions whatsoever, you might have the the patient still sitting with you, then I don't mind giving me a call. If I'm able to help, I'm happy to do so. Back to you, Alison.
Thanks very much, Tammy. That's fantastic. The practices I've been to at the last week, they're like, yay, Tammy, this is so good. We've got this amazing contact now. So I was really fascinated to hear those statistics that you were talking about in terms of the referrals that you're getting and the groups, especially how high that disability percentage is, because that's another focus area that I work in. And I think too, you know, that over 55 we keep seeing in the media, and that's becoming a really big issue for women of that age group, and homelessness is increasing in that age group. So I think it's really important for us to know about those statistics as GPs. So just a quick plug at the end. If you haven't had myself or one of the other educators come out to your practice, please contact Steph and she will organise that. Like I said, I really enjoy these sessions. I've been having a great time meeting lots of GPs and practice staff and doing lots of education as well. So it's 2 sessions, 2 one-hour sessions, and the first one is targeted at your whole practice, and we talk about it more from a public health perspective, what to do if you've got a patient, friend, family member that discloses, and how you might respond to that. And we talk about responding as a practice and you know, the referral systems and those sorts of things. The second session is very much targeted at clinical staff, so your nurses and your doctors in your practice, and we talk more about the referral system. We talk through some cases, how you might support them in your practice, and kind of have a lot more discussion. So both sessions are very much a great discussion, and it's been great. The practices that have really got on board and brought all their practice staff, the admin, reception, everyone's got a lot out of this session, particularly that first one. So I really encourage you to contact Steph, and that's the contact there. And just as another thing, if you didn't get the numbers or anything to contact Tammy, they have updated the health pathways, so all the contact details are also on there. So I know we're sort of over time, but I don't know if there are any questions.
There were no questions today, but I do want to thank everyone for their time, because that information is so valuable and really important that we're sharing it and getting it out there. So the slides will be up on our website in a few days' time, so you can refer it on to anyone else as well as share it, which we will be doing from the PHN side. But thank you, Tracy, Tammy, Alison, as well as Steph, for all of your hard work and getting this session across. We'll see everyone later.
Thank you.
Thank you.
Bye.